Thank you. Thank you for the wonderful introduction. And I am so grateful to all of you for having me here today. So we got a nice intro briefly to what the Poverty Fellows Program is, but just briefly, I'm Gwen and I'm a new National Poverty Fellow. I just started about 3 weeks ago, so I can't tell you how I'm changing the world quite yet, but maybe in another few months. But today I'll be sharing some of my dissertation research that I think will be of interest to this audience, and I'm really eager to hear your comments and feedbacks as a multidisciplinary audience focused on a lot of different aspects of poverty. And so before we begin, as we already said, I'd like to ask two things first, just to hold questions. I was going to ask that anyway. That's how my department did it, and it didn't even occur to me that you might ask questions during the presentation, so we'll hold those till the end. And then second, just if you do ask questions, especially if you're wearing a mask, if you could please speak up and enunciate. I'm hard of hearing. I do have hearing aids in, but I would just really appreciate it. So thank you. And let's move on. So I'd like to begin with a land acknowledgement, where the lands were Case Western Reserve University, where I did my graduate research, and also the greater Cleveland area, where a lot of my research was focused, is located on. So I express my gratitude and appreciation to those who lived and worked there before me, those whose stewardship and resilient spirit makes my residence and work possible on the traditional homeland of the Lenape or the Delaware, the Shawnee, the Wyandot, the Miami, Ottawa, Potawatomi, and other Great Lakes tribes, including the Chippewa, Kickapoo, Waya, Piankashaw, and Kaskaskia. And I also acknowledge the thousands of Native Americans who now call Northeast Ohio home. Case Western Reserve University and the greater Cleveland area occupy land that was officially and coercively ceded by 1,100 chiefs and warriors signing the Treaty of Greenville in 1795. So I'll start the talk today by just introducing myself a little bit more so you can understand the approach that I've taken to my research, and then I'll identify some of the problems and gaps in our knowledge areas in just one of the areas of my doctoral work, which was understanding the experiences of low-income Black pregnant and postpartum women during the COVID-19 pandemic, especially in relation to the COVID vaccine, and the roles that community health workers played for them. And then lastly, I'll discuss the implications of these findings more broadly for work in community-based and population health research. So just starting off with my background and a bit of an introduction to the work that I'm doing right now with the Office of Community Services through the fellowship. So through the National Poverty Fellows, we're each housed within a different office in Health and Human Services. And I'm in the Office of Community Services, which partners with states, communities, and agencies to reduce the causes of poverty, increase economic opportunity, and economic security of individuals and families, and to revitalize communities. And the office runs a number of programs and grants that are aimed at improving household financial well-being and creating community stability. So at OCS, I work on the Low-Income Household Water Assistance Program, which provides financial assistance to those who experience the greatest burden for paying for their drinking water and their wastewater. And I'm happy to chat more about that program and the work that OCS does afterwards or over email if anybody wants to learn more. And since I'm new to you again, and I may be coming from a bit of a different research background, I thought I should give a little overview of my training and the lenses that I'm taking with my research. So I began my undergrad at Ohio State, my research journey with work that examined chronic physical stress, or allostatic load, in American Samoans, really tracing the impact of colonization, globalization, and other Western cultural forces. I then decided to get more training through a public health lens, and I went overseas to the University of Eastern Finland to get my master's degree in public health. And there, my research also focused on stress, but it was looking at sources of childhood stress in Finnish men and how those were associated with lifelong dementia risk. And then finally, I moved on to get my PhD in epidemiology and biostatistics from Case Western Reserve University, which is in Cleveland, Ohio. And I'll talk in a little bit more detail about the other work I was doing there, which was with the Swetland Center for Environmental Health, because I think there could be some possible interest in this room in hearing about that. But briefly, my dissertation work was examining stressful events, including residential instability and COVID-19, and the respective impacts that those had on food access, and then experiences during pregnancy and the postpartum women among low-income Black pregnant and postpartum women. So you can see that there's been a trend across my research foci with trying to understand the experiences and impacts of stress and how it relates to poverty and population health. And I want to just briefly talk about the work that the Swetland Center does. Sorry, it looks a little different on there than it does on my screen. Because I think that there might be some folks in this room who are interested in that, and there might be some collaborative opportunities with other researchers at the Swetland Center. So the mission of the Swetland Center is to study the complex interplay of environmental determinants and population health outcomes, and they place a special emphasis on community-engaged approaches that address the role of structural racism in creating and sustaining environmental health inequities. And the center really works to translate these findings into policies and practices and relationships that promote community and population health equity. So at Swetland, I and others were working on a number of projects related to food access and equity, including studying environmental modifications, like introducing new healthy food retail, then financial programs like farmers markets incentives and SNAP and WIC programs, and then community-based interventions like training and funding local Black food entrepreneurs. And I was primarily involved with a community-based system dynamics modeling project whose aim was to unpack the structure and key components of Cleveland's urban food system so that we could better understand why so many of the food-based interventions that we were trying to implement were not having the success that we wanted them to have. And that could be a whole separate presentation, so I'm happy to discuss that at another time with anybody who's interested. But anyway, at this point, I would like to transition to discussing some of my dissertation work, which isn't published yet, and I'm really interested in hearing your perspectives and feedback as poverty researchers from a really wide range of disciplines. So at this point, I'll define the problems and knowledge gaps that I wanted to address with my research. And again, the focus of this talk will be on the experiences of low-income Black pregnant and postpartum women during the COVID-19 pandemic and the roles and importance of community health workers who are working with them through a city-led initiative to reduce maternal and infant mortality. And the thematic analysis that I did was designed to look at health-related decision-making among Black pregnant and postpartum women in the context of the systems that frame that decision-making. So specifically, historical abuse of the Black population by medical and scientific systems, redlining and related policies that made it very difficult for Black Americans to build up wealth and escape poverty, and then resilience through community building. And the analysis will also look at the complexity of COVID-19 vaccine acceptance among Black pregnant and postpartum women, which was and continues to be poorly understood, as well as the myriad roles that community health workers filled for this population, including financial advisors, resource navigators, and healthcare consultants.
We're going to try and move a little room.
Yeah, no worries at all. Are there extra chairs anywhere that you want to bring in?
We're young.
Unlike the poverty fellows. Okay.
Thank you, sorry.
Okay. Everyone good? Are there any, there's one chair over here, if someone would like it. Make sure you don't get hit by the door.
Oh, yeah, you don't want to be.
Yeah. Okay.
Thank you, sorry.
Oh, no problem at all. So for a bit of background, research over the past couple of years and starting early in 2021 or 2020 really rapidly demonstrated the heightened severity of COVID infection among pregnant women, which included a 70% increased risk of mortality and twofold increased risk of intensive care unit admission, intensive ventilation, and ECMO, which is a life support technique, compared to non-pregnant women. And maternal deaths rose 14% from 2019 to 2020, with the highest increase among Black women being 3 times that of white women. And a third of pregnant women who died in 2020 were Black. And I would also like to pause at this point just to say that this presentation is going to have some very heavy topics that are very real and some quotes that are very emotional. And so just be aware of that. And I understand if you need to take time to not be a part of that. So some of the reasons for those disparities included COVID infection, problems with telehealth, trouble getting to appointments, and toxic stress. Pregnant women with COVID also have greater likelihood of preterm birth, preeclampsia, coagulopathy, and stillbirth compared to pregnant women who don't have COVID-19. So just for some definitions, preterm birth is birth before 37 weeks of gestation. Preeclampsia is characterized by high blood pressure and damage to the kidneys or liver, and it can be fatal to the mother or infant. Coagulopathy includes multiple conditions that involve bleeding or clotting, and then stillbirth is defined as the loss of a baby before or during birth. So here's some further evidence for why it was really important to look more closely at the experiences of COVID-19 and COVID vaccine acceptance among Black pregnant and postpartum women. So first, we know that COVID disproportionately affects racial and ethnic minority groups in the United States through mechanisms of toxic stress, barriers to healthcare, occupation, and housing. Next, COVID is likely to and may already be endemic, which we can likely all agree on after seeing its trajectory over the last couple of years. So this could be supported through immune escape, which is just the strategies that a virus uses to evade our immune system, waning immunity, uneven vaccine distribution, vaccine hesitancy, lack of political will, and animal reservoirs. Also, although infectious diseases have long emerged in human populations, they are emerging more now due to factors like globalization, mobility, urban density, and population size. And then finally, COVID vaccine acceptance is really indicative of broader trust in medical systems and health science. So there was a systematic review done that was looking at global COVID vaccine acceptance in pregnancy. And pregnant women were much more likely to be receptive to the vaccine if they had confidence in their public health agencies and they'd been exposed to explicit communication about the safety of the vaccine during pregnancy. And in the United States, COVID vaccine acceptance in pregnant women is among the lowest in the world, alongside Russia and Australia. So these trends really point to a broader need for trust building between pregnant women and public health systems. So one of the main aims of my dissertation was to examine COVID vaccine equity and acceptance among Black pregnant and postpartum women. So several studies have been published assessing COVID vaccine acceptance in general populations, among pregnant women, among healthcare professionals. And these studies have indicated that in the United States, among pregnant women, there's very low vaccine acceptance, particularly among non-white and non-Asian women. Those who have low vaccine acceptance are worried about vaccine safety or harm to their fetus. And in some areas, very large proportions of health professionals are also vaccine hesitant. So to fill these gaps, my dissertation largely focused on COVID vaccine acceptance. And in conducting this research, I learned that there was a whole additional side to this story of COVID vaccine acceptance and lived experiences during the pandemic, and that was community health workers who were working with pregnant and postpartum women. So with that, the research questions that are going to be addressed in this presentation are first, what has COVID-19 vaccine acceptance looked like within this group of women and what factors have influenced it? What were the roles and importance of community health workers for low-income Black pregnant and postpartum women during the COVID pandemic? And what are some of the broader applications of these findings to health communication and trust? And I'd also like to note that these questions were developed after conversations that I had both with Black pregnant women and people who work with Black pregnant and postpartum women across the city. So I use these conversations as ways to get feedback and insight into what questions were the most important and relevant to them, and what was emerging as things that needed to be studied more as the pandemic continued. And I also want to take a moment to operationalize race here. So this is a big issue in population health. I'm not sure what the discussion looks like in the world of economics, but in population health, there's a lot of conflation of race and ethnicity and ancestry. And so even when you have race as opposed to ethnicity or ancestry, sometimes it's very unclear how it was actually defined in a study and measured. So in this study, race was self-identified, so the participants self-identified as Black, and they confirmed this in the screening process. So here I used a qualitative case study design. So qualitative case studies are really useful for examining a complex specific phenomenon, and they can be used as part of an exploratory mixed methods approach to assist with question and hypothesis development. And this type of case study is especially useful for when you're trying to answer how and why questions as opposed to just what. And when the context surrounding the phenomenon is really critical for understanding the case. So I also use data that I pulled each week from the CDC and the Ohio Department of Health for vaccination and other COVID-related statistics among pregnant women to provide context. And then I interviewed both pregnant or postpartum women as well as community health workers to look at the complex case. And using a qualitative approach here was especially useful because, as I mentioned in the background, most of the research to date that was looking at vaccine acceptance was using survey designs, which can often miss the nuance that surrounds really complex decision making. So here the participants were the ones defining what had meaning and importance rather than me, the researcher. And using this kind of in-depth qualitative approach really helped me capture a broader range of information and meaning, which can then better inform quantitative work that's directed at a broader population. And so all that said, the goal of this was not to establish generalizability, so I don't want you to leave saying, like, I learned that this is true of all Black pregnant and postpartum women. That's not what this is. But the point is to generate new questions and hypotheses that can help guide later work directed at a larger population level. So to answer my research questions, I started first with a collaborative recruitment approach for finding community health workers and women to interview. So the community health workers were working for a city-led initiative that was designed to improve maternal and infant health outcomes, and pregnant women were participants in that initiative. So community health workers were contacted by the initiative's director, who I'd been working with, and I then reached out to enroll them, and then enrolled community health workers shared flyers with their clients who could then contact me to learn more and go through screening and enrollment. And so on average, the pregnant participants were about 27 years old. Annual household income was under $30,000, and most had graduated from high school. The average household size was 4.4, including an average of about 2 to 3 children, and the other children's average age was about 6. And most had lived at their current location for less than 1 year. In total, each participant, so both the community health workers and the pregnant or postpartum women, was interviewed 2 to 3 times between December 2020 and June 2021. So I conducted 35 interviews in total across the 14 participants, and there were at least 2 months between each participant's interviews. In addition to that, I conducted 12 feedback calls for data validation between June and September of 2021, and all pregnant participants had given birth by the time of their final interview or feedback call. The interviews were about an hour each, and they were conducted over Zoom due to university data collection restrictions. And they were conducted any day or time during the week. And the topics that we discussed included experiences with prenatal care, experiences of racism and discrimination in healthcare, perceptions about the COVID vaccine, financial stress and other stress, and then use of the government-issued stimulus checks. So I developed a preliminary deductive codebook using the interview guides and the theories that were framing my work. So that included the health belief model, the health equity model, the theory of healthy lifestyles, and then concepts from racial justice. And I'm not going to go into those frameworks now because that would take a long time, but I'm happy to discuss them more if anybody's interested. So here, just if anyone's less familiar with qualitative work, deductive means that those codes came from existing literature or theories or frameworks. So I coded 5 interviews using the preliminary codebook, and then I added inductive codes from salient themes in those interviews. So inductive means that those codes were developed from new ideas that emerged from the interviews. And then I recoded all of the interviews using the revised code book. So once all interviews were coded, I then applied the themes to a conceptual framework that, again, I can discuss later if somebody's interested, at each interview to understand how these concepts were changing over time. Another relevant factor for the whole study, including coding, is that I was about 8 weeks pregnant when I began the interviews, and I gave birth in July 2021. So there's this interesting intersection of being pregnant alongside my participants, and really having this insight into what it meant to be pregnant and give birth during the COVID pandemic. And this really did help me build trust and rapport with the participants. That being said, I also think it's very important to note that I was and am a white woman coming from an academic setting. And so there were definitely barriers that participants may have felt in communicating with me, especially because things weren't in person, they were over Zoom. So first I'll look at one of the major focuses of the interviews, which was COVID vaccine acceptance and the roles that community health workers were playing for their clients. So first we have this theme of perceived risk, which includes perceived susceptibility to COVID, given vaccination status, and perceived severity of COVID. So an example of how perceived severity emerged from conversations that I had with pregnant women. My cousins down south had it, so I know it's serious. One of my family members is in the ICU, and she's been in a coma. So this participant is perceiving COVID as very serious because somebody in her family had it and had a bad case of it. Then we have perceived susceptibility. I'm not worried about getting COVID because I've been following the rules since it came out. Then we have this idea of perceived agency or self-efficacy, which is confidence and ability to maintain health. Given vaccination status. So this participant says, I feel like the COVID vaccine is the flu shot. I've never got the flu shot. I feel like if I stay away, I'll stay healthy. So there's strong self-efficacy here, strong feelings that they are going to be able to maintain good health status regardless of having the vaccine. Then we have this idea of pros and cons, benefits, reasons to vaccinate, or barriers to vaccination or reasons not to vaccinate. So an example of perceived benefits, I guess it's helpful for people with preconditions that they already have something like heart problems, asthma. And then barriers. I have my concerns. I think my concerns come from history, and more on that later. I don't particularly want something that I know has not been fully tested on anything. It hasn't been fully studied. Then we have the concept of health literacy, which was structuring a lot of different themes that arose during the interviews. So health literacy could structure self-efficacy. For example, you let your body do what it should do naturally. We're designed to vaccinate ourselves, but we let medicine, pharmaceutical companies take over. And then structuring perceived benefits or barriers. What else is scary? Because the doctors, they get paid to give you vaccinations. So the doctor tell you all these pros, but the last side effect is death on most vaccinations. Then we have the concept of cues to action. So these were either things that happened or other events that made people firmly decide to vaccinate or not to vaccinate. So an example of a cue to action, some of my family recently decided to get vaccinated because I just had a death in my family over COVID-19. And then what I found was that the source of that cue to action was really, really key as well, which you can see in the previous example, it was a family member. So an example here, I wouldn't take it while I'm pregnant. My mom-in-law did it. Everything seems fine. I will give it a try after I have my baby. So it's important that it was the mother-in-law here and not just some stranger on the internet. Something that also emerged as structuring themes across the interviews were different power structures. And so we have historical power structures that were brought up, and then also the government was brought up a lot. So first, in the African American community, historically, we have a history of being little guinea pigs when it comes to different things, and we tend not to trust because of that. So when the vaccine was announced, a lot of us were just like, yep, nope, I'm not doing it because I know what happened before. And then we also have people referencing the government. The government is trying to make me take this vaccine. I feel like that's trying to take advantage of me. So now we're just going to look at how the decision to vaccinate or not was shifting over time. So this shows attitudes towards vaccine acceptance among the community health workers. And as a reminder, participants had between 2 and 4 contacts with me, including up to 3 interviews and a feedback call. And when coding interviews, I examined their attitudes towards vaccination. Oh, you're fine. I examined their attitudes towards vaccination and gave them a numeric score based on how receptive to vaccination they were. So a 1 here meant that they definitely did not want the vaccine. 2 was they most likely didn't want it, but they had some considerations. 3 is they're really unsure in either direction. 4 was they were strongly considering getting it, but they really hadn't made the call yet. And then a 5 was they had decided to get vaccinated or they already had been vaccinated. So this first graph refers to the community health workers' own vaccine acceptance over time. And this is really important because of that cue to action concept. So community health workers were trusted, reliable sources of information for participants. They represented knowledge and expertise and that they were considered health professionals. But they also had these stronger, longer-term, deeper relationships with their clients than any other health professional would. So because of this, their own views on COVID vaccination were really essential for understanding how they talked about the vaccine with their clients. So just to give some examples, the first group of community health workers did not change their mindset about vaccines for the duration of the study. So the first one over here stayed as a definitely no the whole time. She distrusted all vaccines. This was not just about COVID, although she did express some specific concerns about it. So she told me, honestly, I don't believe in vaccinations, period. And then this other community health worker was worried about the vaccine interacting with an underlying condition that she had. And she kind of stayed leaning no the whole time. So she wasn't specifically against the vaccine, but she was worried that it might affect her health condition. So she said, I'm not against the COVID vaccine. I'm just nervous about the COVID vaccine. So for those who did change their mind to become more COVID vaccine accepting over time, what were the cues to action? So for one community health worker, it was fear about exposure during travel. So she had high self-efficacy, meaning she had high confidence in her ability to maintain her own health, given her non-vaccinated status, but her perceived self-efficacy declined and perceived susceptibility increased with travel. So she said, I didn't want to get over there and get sick. Then this one here, she got infected with a fairly severe case of COVID, as did other members of her household. And she also had high self-efficacy, and then this is kind of a long quote, but I think it's important. So she told me, it's totally changed my perception on a lot of things. I already followed the safety protocols. I wore the mask. I stayed away from large groups, did everything. I'm still trying to figure out where it could have been. And she also told me, it's not a situation where I was always out and not wearing a mask. I honest to God followed everything. I was paranoid to the point where I didn't let people close to me. If I didn't know you, I just didn't go. I didn't go out to different events. I was really a homebody. So to get it and you followed all of the rules, it's a different perspective versus if I was a person that was just out and about all the time, not following protocols, always in big large crowds, all not wearing a mask. Then I could see how I could get it. But to be a person that's trying to follow the rules and do everything and to get it, I explain to my clients, nothing is 100% foolproof. So after she got COVID, her perception of COVID severity drastically increased, and her perceived self-efficacy decreased. And then finally, this last participant had asthma and decided to get vaccinated when her healthcare provider explained her specific risks for COVID severity. And if you'll recall from the introduction, that also emerged as something that was an indicator of whether pregnant women were going to be more receptive to the vaccine, if they had that clear and explicit communication from their healthcare professionals. So she originally said she would never get vaccinated because she felt that it was untrustworthy. And then later she said she still didn't want it, but she began telling her clients to consider it. And then eventually she changed her mind and she did decide to get it. And so this is really an example of how some of these concepts can be quite malleable. So when 2 different people say, no, I don't want the vaccine, it does not mean the same thing. For one person, that means no, forever no. And for one person, that means I just haven't heard the right information yet. So this chart shows COVID vaccine acceptance among the pregnant participants, and they also had between 2 and 4 contacts with me. So this first group resembles that first community health worker and are really exemplified by this quote, "There's nothing they can do to make me." So they made it clear that they absolutely did not want the vaccine. And one of them felt this way about all of the vaccines, and for another one, it was specifically about the COVID vaccine. This next group of participants shifted their perceptions to become more vaccine accepting over time. So for some of them, this shift came from the perceived safety of the vaccine or its perceived benefits. So one of them said, "It seems like it's going well. That's what I've seen." So she'd seen friends and family get vaccinated without adverse side effects, and the power of seeing and hearing those personal stories from trusted cues to action was really apparent across the interviews. And for another, and this was actually the sole pregnant participant who did get vaccinated, and actually she got vaccinated in the postpartum period, so not while she was pregnant. Her perceived severity sharply increased after knowing people personally who had become ill or died from COVID, and she was worried about getting COVID and transmitting it to her family or of dying. So she said, "I catch COVID, then I bring it home to my kids, or I don't make it home to my kids." Then there's another category of participants who became less receptive to the vaccine with time. And so for both of them, hearing about breakthrough infections or those COVID infections that happen to people who have been vaccinated were driving those perceptions. And at the time, this was really rare. This was pre-Delta and Omicron. Breakthrough infections were not happening. But you would see those stories on social media, and that was a really strong deterrent to them to get vaccinated. So one of them made it clear that her perception of the risks of the vaccine or her perceived barriers really far outweighed the perceived benefits because she felt like her susceptibility wouldn't change at all even if she were vaccinated. So saying somebody get COVID after they already had the vaccination, so what's the point of getting a vaccination if you could still get COVID? There were some other key findings that came out of this work. So first, many participants showed new mistrust of other vaccines, like this community health worker who said, "It make you think about all the other vaccines. We really don't know what's in these little things they put into our body. We don't really know." Second, and this was interesting to me, while a lot of early work around vaccine equity focused on convenience or access to vaccines, this was not a perceived barrier in this group. So participants knew how to make appointments and they didn't have trouble getting access to the vaccine if they wanted it. So this participant told me getting appointments has been pretty easy. It only takes like 3 minutes. Third, there were very few cues to action from healthcare. So if you'll recall from the background of this aim, one of the most important factors for determining vaccine uptake among pregnant women was clear communication from their healthcare professionals about the safety of the vaccine in pregnancy. And if you haven't been pregnant before, you might not know about the sheer number of contacts with healthcare that happen. You have appointments at least once a month, and that only increases in frequency as the pregnancy progresses. So ample opportunities for healthcare communication that was not happening. Almost no participants had gotten information from their healthcare providers about the COVID vaccine, and because of that, they were either not discussing the vaccine at all, or they were discussing it with their community health worker. There was also increased exposure to COVID because of high-risk employment among both the participants and then other clients of the community health workers. So that included food service, factories, healthcare and nursing homes in the service industry. And then finally, the perceived barriers to getting vaccinated sometimes decreased after giving birth. So for example, this community health worker said that her pregnant clients didn't want the vaccine, but that if they thought it would benefit them after giving birth, then they might do it. And so this points to a potential compromise between health professionals and pregnant women, where it may be too challenging to encourage vaccination during pregnancy, but postpartum vaccination might be more achievable. And clear communication about the vaccine should also continue after giving birth. So it might be beneficial to work with community health workers to convey really clear information about vaccine safety during the postpartum period when both they and their clients might be more receptive to encouraging or taking the vaccine respectively. So through developing this really thorough understanding of vaccine acceptance and hesitancy, clarity began to emerge around all of these different roles that community health workers played for their pregnant and postpartum clients. So their role at baseline, kind of defined by their parent organization, was to provide emotional and resource support throughout the pregnancy and postpartum period, and to help their clients ensure that they and their babies had what they needed to survive and thrive. But this role included a really wide range of activities that only became apparent through these in-depth interviews. So, as we discussed earlier, we've already seen that COVID disproportionately burdens Black populations in the United States, and that Black pregnant women experience additional stressors like rising severe maternal morbidity, preterm birth, and low birth weight. And then COVID brought all of these additional hardships, especially financial hardships. And so community health workers helped address these stressors and challenges through providing health information, financial advice, job counseling, resource navigation, and advice with household decision making. Their clients often had trouble navigating the massive amount of information available to them on all of these topics, and their community health workers helped them identify what was important and what wasn't. So, for example, one community health worker told me, "The internet is the devil, I guess you could say," because they, pregnant women, heard so much on the internet that they're just like, "I'm not even going to do it in here. That's get vaccinated." I'm not. So I guess it's a good thing and a bad thing at the same time. At least I know they're actually researching it. So as discussed in the prior part of this presentation, community health workers were a really key source of health information. And that includes both about the COVID vaccine and other vaccines for their clients and their clients' children, prenatal appointments, and postpartum care. And so to provide an example of how one community health worker communicated with her clients about the COVID vaccine, she told me this: "We all get vaccinated, they open up the world, we think we have a minor cold, but no, we have COVID, but we all back out. Guess what's going to happen? Going to spread because it don't prevent it." And this deep-rooted distrust in medical systems that pregnant and postpartum participants expressed was a feeling that was shared by many of their community health workers. And one described her feelings about medical research and consent, and I apologize for the long quote here, but I think it's very powerful. So she told me, "Doctors try to get our children's blood for another study without your permission. That's what one of our clients," she was like, "well, they wanted my baby to participate and give some type of blood. They said it will be good for them. And I said, it's your choice. You don't have to." So she told the doctor she didn't want to. And I was explaining to her, "You don't have to listen to me, but it's your choice." I tell them, doctors try to do studies on babies without your consent a lot. And these feelings can be put into the context of very real historical and current examples of abuse, coercion, and hidden agendas by researchers and by the medical community when working with Black Americans. So we have some of the more prominent examples like Tuskegee and Henrietta Lacks. Then we also have biological anthropology as the underpinnings of eugenics in the United States. We have James Marion Sims, who's claimed as the father of American gynecology, but he learned all of his things by conducting inhumane experiments on Black female slaves. Concepts of implied consent, which is in some states there are laws that say unless you've explicitly signed papers saying that you don't want parts of your body or your organs donated after you die, then they can be taken without consulting your family members. And then prison experiments happening more recently and then also longer in the past. So we'll shift a little bit now to financial advice. So community health workers also provided financial advice to their clients, including recommendations for how to spend the economic impact payments during the pandemic, and suggestions for building up savings, and goal setting for longer term financial goals. So in one interview, a community health worker told me about how she had started to provide informal financial counseling to her clients around the COVID stimulus payments. So she said, we have clients who go and put money down on a car, but they're not working. They'll have a car for 4 months, and then in month 5, you don't have a car because you can't pay the car bill. And so she was encouraging her clients to pay for things that didn't require additional expensive follow-up costs like cars do, and strongly advised saving. One of the other community health workers told me how she discusses savings with all of her clients each year, I kind of stress on my clients between January and April 15th, tax time. I always try to push them to spend on the necessities and save. And this was a really common theme for community health workers, with another saying this: I try to talk to them about just financial responsibility and nothing is promised. You're not secure. You don't necessarily have to save all of your money, but put some away. Take care of the things you need to take care of. Pay your bills, of course. Get what you need for your babies. Get what you need for your kids, and then build a nest egg. And another community health worker told me about the financial stressors that were facing her clients, like the threat of eviction once the moratorium was lifted, and even prior to that. So are you okay? With the COVID, your landlord isn't supposed to give you an eviction and kick you out and all that, but some of my clients still even experience that. Community health workers also provided both empathy to their clients who were unemployed, as well as practical advice for job seekers. So this one says, I encourage them to use your skills. If you know how to do hair, that can give you extra money also. But we've been trying to find employment or work, and it's just kind of difficult right now. I have some that work in fast food, service industry like hotels. I have a few that are in nursing. And recall back earlier when we talked about how these are really high exposure careers as well to COVID infection. And I try to give them job leads as best I can. Another role that community health workers filled, which might come to mind more quickly, is that of resource navigation. So they helped their clients with understanding and applying for programs like SNAP and WIC, and learning where they could access emergency food assistance through food banks or pantries, and getting other physical resources like diapers, clothes, or other supplies. So for example, one pregnant participant told me, I don't get WIC no more. The WIC office closed down. They got a long wait list, so it closed down with COVID. And her community health worker helped her work through pandemic-related barriers to accessing WIC and ultimately get the food that she needed. And I'm thinking back yesterday to Sarah's brown bag presentation about administrative burden and how all of this could have really drastically changed during the COVID times, and what that looked like for a lot of populations. So in another interview, a community health worker told me about some of the things that her clients get no matter what. So they get pack and plays, lay out with blanket, some sleepers, socks and stuff, clothes, coats. And lastly, community health workers also provided feedback and advice on household decision making, like romantic and non-romantic relationships and cohabitation, home ownership, transportation, and a lot more. So one told me about how she counsels her clients who want to own their own homes. A lot want to buy homes, put money to the side, save it, and then you shop around. I want them to be smart. And another described how she encourages cohabitating male partners, non-cohabitating fathers, to participate actively in the child's rearing. So we have a fatherhood peace program. I would ask my clients, do you think you would be interested in the fatherhood program? So just tying this all together, the perspectives and philosophies of community health workers were often shaped like things like historical medical abuse and medical distrust. And this helped shape the lens that they used when working with their pregnant and postpartum clients. And as I discussed earlier, multiple participants independently brought up historical examples of coercion and times when trust was corroded between health professionals and Black Americans. And coupled with policy-supported practices of racism, discrimination, like redlining that took place in Cleveland and many other areas across the country, there's ample history to justify the distrust that the community health workers and their clients were feeling. With all that, community health workers also represent a really critical population for working with low-income Black pregnant and postpartum women, as they possess medical resource and localized knowledge and expertise. And they also occupy many of the same identities and spaces as their clients do. So this intersectionality really uniquely positions them to help ensure that this population of women gets the resources and information that they need in order to have a physically and emotionally healthy pregnancy, birth, and first year of their child's life. So the work presented here highlights some of the complexity underlying health and household-related decision-making during COVID for low-income Black pregnant and postpartum women. and understanding the ways in which community health workers can be leveraged and supported is a really critical intersection here. So distrust of science and health providers was very pervasive among both populations that were interviewed. Community health workers were really essential sources of information about the COVID vaccine, COVID risk and safety, access to and advice about the government stimulus checks through the CARES Act, and COVID-related housing challenges, and a lot more. Community health workers represent an important group for effectively communicating about COVID-19 and about household level challenges that it created for Black pregnant and postpartum women. It's really necessary to examine these interactions in the context of complex historical, economic, and cultural systems, and building trust and rapport between health professionals and Black pregnant and postpartum women may help accelerate COVID-19 healthcare goals and healthcare goals far beyond COVID. So the conclusion I came to from this work was that engagement with community health workers also needs to go beyond training and seminars. It needs to move more towards co-design, with community health workers actively part of the decision-making process with hospital systems and health scientists to understand how to improve the health and well-being of low-income Black pregnant and postpartum women. So I heard a lot about trainings and one-pagers that they were given about COVID, about the vaccine, but not anything about ongoing inclusion in decision-making and showing consistent respect for their and their clients' lived experiences. And so I believe that co-design represents one of the ways that this might be achieved. So personal experiences, stories on social media, the experiences of friends, family, and other trusted people were really strong determinants of beliefs related to COVID. And those were often stronger than different statistics that may have suggested things like vaccine safety. And this shows one of the ways that something like perceived susceptibility to COVID is structured and how it can be easier to shift in one direction than another. The source of cues to either vaccinate or not was really essential, as well as for decisions related to finances and households. So sources were trusted, reliable people, often family or friends, and very frequently the community health workers themselves. And it meant that one experience that someone close had with COVID held much greater weight than something like CDC reports. It was also clear, excuse me, it was clear throughout the interviews that there was significant distrust between healthcare with a capital H and many of the participants. So people were concerned about becoming an experimental population for the vaccine, or they felt that COVID was man-made or being inflicted on specific populations. And with that being said, when a voice in healthcare was trusted, their words went a really long way. And community health workers were one of those voices. And so here's an example quote, and I'll let you guys read it while I drink water. I said I would let you read it, but I mean, this last part of it, it's like you go to the doctor and they don't even remember who you are. And that really summed up a lot of what people felt. This study had a very small sample size, which is often the nature of in-depth qualitative work. But what this showed me was that even in a group that you might think would be very homogeneous, here meaning low-income Black pregnant women living in the same city, participating in the same initiative, there was a lot of heterogeneity around perceptions related to COVID and the vaccine. And this has implications for work that we do on broader scales, designing outreach and interventions based on what we're deciding is generalizable. And so this kind of work can potentially help inform these approaches or other larger studies to better capture that variability within groups. Briefly, some of the limitations of this work was that participant contact stopped before the Delta or Omicron variants emerged, which really may have driven vaccine distrust more. And in addition, I needed to conduct everything over Zoom, which had its own benefits and drawbacks. So I'm really grateful to my funding support and to the Moms First initiative in the city of Cleveland. And mostly a huge thank you to everybody who participated in the interviews, was so open and honest with me and authentic, and also to my undergraduate co-researchers who helped me transcribe, and to my committee for all of their feedback and support. And I'll just end us with a take-home message, and thank you so much, and now I'm happy to take any questions.